Today's guest on the Keen on Yoga podcast is Dr. Louise Newson, GP and menopause specialist, founder of Newson Health in Stratford-upon-Avon, and author of several best-selling books, creator of the Balance app and Louise Newson's podcast, excellent podcast as well, you should listen to, and a practitioner, I learned recently, of Ashtanga Yoga. So welcome, Louise, to Keen on Yoga.
Oh, thanks. Thanks for inviting me. It's great to be here.
It's such a pleasure to have you, having listened to so many of your podcasts recently, and really been interested in obviously a subject which I have no direct experience of, but I do teach many women of this age. So, you know, it's, I think to yoga practitioners, to all women, obviously, but this is going to be a very interesting podcast, I hope. So to crack it open in the most obvious note possible, what is menopause and what is perimenopause for people? How did you find that? Yeah.
Well, great question, but it's really frustrating actually, and I hate the words because it doesn't really describe what it is. So menopause, if you break it down, means stopping periods. So the official, if you like, diagnosis is a woman who hasn't had a period for a year becomes menopausal. And perimenopause, peri is a medical term for meaning around the time of. So around the time that your period stopped. Like, what does that tell us? It tells us nothing. It tells us that gynecologists trying to control us by what's going on with our wombs, actually. And I have an issue with it for a few reasons. Firstly, some women don't have periods. They might have had a hysterectomy or they might be using Mirena coil or contraception. So then how do they become menopausal? But the bigger thing is it's not explaining to anyone what's going on. And so what is happening is that our periods stop because we have less hormones in our body. And these are hormones that are made in our ovaries that determine how our periods become regulated, how we ovulate and produce eggs and become fertile or what have you. But these hormones are estradiol, which is a form of estrogen, progesterone and testosterone. But they're also made in other organs of our body, including our brain. So essentially what's happening is these hormone levels become low, and they become low enough that our periods stop, but they become low in every single tissue and organ in our body as well. And for many women, the decline of hormones in the perimenopause causes more symptoms because they can become quite chaotic, the levels. So in that time, actually, people often suffer more. But it's a hormonal change. And for some women, it's more of the testosterone. For some women, it's more of the progesterone or the estradiol. So we should be more specific really and talk about, which hormone it is and what's going on. Because a lot of people think, oh, it's just some flushes, my periods stop, and then I'm through it. Well, actually, they're not through it because their hormone levels are low and they stay low. And that can cause symptoms. But more importantly, for me as a physician, it can lead to increased risk of diseases, and diseases that are very common, and they're more common the longer we live. So, as a physician, it sounds a bit weird, but I don't like seeing patients who are ill. I want to keep them healthy. So that's where changing the narrative and thinking about what's actually happening to our bodies when we become perimenopausal or menopausal is more important than these words that are just very old-fashioned and don't really help women.
Yeah, because they certainly do give the impression that, well, okay, I'm done peri and now I'm into my menopause and now I'm done that and it's over. All done, nothing to see, nothing to do anymore. Which is definitely, having listened to many of your podcasts, not the case. What might be expecting in very, I mean, I know it's a very vague kind of thing to diagnose, but what kind of symptoms might be expected? Do they differ in perimenopause and menopause? And secondly, as you answer that question, would they differ depending on what you're low in? If you're low in estradiol or progesterone or testosterone?
So it's a great question. And it really varies. Like, everyone's experience is completely different. And so that's really important because there are many people out there saying, look, it was fine for me, so therefore it's going to be fine for you. Or it was awful for me, therefore it's going to be awful for you. We are all different. But as a generalization, and I've come from having a huge amount of clinical experience and knowledge as well, is that women often suffer more, especially with mental health symptoms during perimenopause, when hormone levels are fluctuating. And the most common symptoms are symptoms affecting our brain. So symptoms of low mood, irritability, anxiety, reduced self-worth, low self-esteem, reduced confidence, just feeling flat, just feeling joyless, no motivation, memory problems, fatigue, reduced libido. These are the symptoms that are not only affecting women, but they're affecting everybody around us, because obviously they have an impact on our work, on our home, on our families, and so forth. And then every single cell needs these hormones to function properly. So every cell and tissue and organ can be affected. So lots of women experience palpitations, headaches. They can get dry, itchy skin. They can get hair changes. Muscle and joint pains can be incredibly common. And then more specific musculoskeletal symptoms, so frozen shoulder, plantar fasciitis, tennis elbow, golfer's elbow, inflammation that can occur. People can get irritable bowel type symptoms. They can get bloating. The list goes on and on, actually. And we've just extended our symptom questionnaire for 72 questions about symptoms. Urinary symptoms are very common. But the symptoms can come and go. In perimenopause, sometimes you feel great, and then other times these symptoms come on and really floor you. In perimenopause, they can last sometimes for 10 years or so. So it's not a short time thing. Menopause, like you say, it's this day when the periods stop, but it will continue. So some people think they don't have symptoms, maybe because their flushes or sweats have improved, but they might be feeling more tired. They might be sleeping less well. They might be getting up at night time to have a wee. They might have some joint pain, but they'll say, oh no, it's just because I'm older. They won't associate it with the hormones. And so that's where it's sometimes hard to know how many of these symptoms are hormones and how much are due to lifestyle or just aging or whatever. Yeah. But when you ask about which hormones do which, that can be very difficult sometimes to know. Testosterone can really affect mood, memory, concentration, stamina. A lot of people actually find that they can't build muscle, and you might have seen that in some of your clients, that they've been exercising absolutely fine, and then suddenly they're just not maintaining their muscle strength and their muscle definition as well, and that's often a testosterone, but it can be related to estradiol and progesterone to some extent as well. But often we don't know until we give those hormones back which are the symptoms that are related. But no one needs to have a certain number of symptoms or a certain severity of symptoms before receiving any help, advice, support and treatment. There's lots of women say, oh, you know what, I don't feel too bad. I'm just going to see how I go. Well, actually, your body's telling you that something's not quite right. But it's not just about symptoms. Even if I had no symptoms as a menopausal woman, if I wasn't taking hormones, I'd have increased bone turnover, I'd have increased inflammation in my body, and increased risk of diseases. And that's where I need to decide as a menopausal woman, how am I going to reduce that inflammation? How am I going to keep healthy?
Before doing this podcast, as a man with many female students, I put it out to my student base and I asked them, what would you like to ask Louise? And one question that comes to mind here is that someone said, is there an increased risk of shoulder pain because of estrogen receptors at the shoulders? So I just thought, throw that your way. Have you ever heard of that?
Yeah. So frozen shoulder is very common, and just any capsulitis and inflammation in the joints, very, very common. And it's not just estrogen, actually. It's often testosterone, and it might be progesterone as well. And I just think back to my days where I used to do a rheumatology job, and then as a GP, I see lots of people with musculoskeletal symptoms, and lots of women that found it hard to reach the cupboard. They found it really difficult. And I didn't even think about hormones. And actually, very embarrassingly, must have been about 9 or 10 years ago, I had probably a frozen shoulder, and I found it really hard to do yoga. I was just like, when you do yoga, you're very aware of when your body is asymmetrical. And I just wasn't able to just straighten my arm as much. And I kept saying to my instructor, it's weird. Like, I don't know what's going on. I haven't done anything to it. And I actually went and saw an orthopedic surgeon who injected it with steroids, and that made a big difference. But then it wasn't until my hormones were at the right dose for me, then I realized oh my gosh, my shoulder's been fine. Like, what was that about? Of course, it was probably related to my hormones. So I didn't really need a steroid injection, probably. I needed my hormones balancing. But we know our hormones are very, very anti-inflammatory in the muscles and joints. So it makes sense. If you don't have them, you can get increased inflammation. And so pain in shoulder is very, very common.
And I think another one that needs to be highlighted is mental health. You've spoken
Yeah,
at length
totally.
in many places I've heard you on, because it's so insidious. You don't really know, is it, what is it? And the people, as you mentioned, they've been given SSRIs or lithium, all kinds of, mental health drugs, when perhaps it's just a hormone problem, even being
Yeah.
institutionalized, when, due to, and of course, in the 19th century, we have the hysteria diagnosis of women, and, a lot of it is probably hormonal. So, I think, do you want to speak on that briefly? Because I think that's, as you mentioned,
Absolutely.
people
I
are
mean,
worried about
it's,
HRT, but then again, it's like, well, if you're going to
yeah.
commit suicide, right, take HRT, well, weigh them up,
It's really, really important, and it's been not thought about for far too long. And in fact, even in the 1800s, it was written about women's mental health, about how people were struggling, and about suicide rates as well, and people going to asylums, like you say, with hysteria. But we've known for a long time that the role of hormones in our brains is very important. We know these hormones are made in our brain. So anything that's made in an organ is needed for that organ. So it's very basic sort of physiology, really, that those hormones are important. And we know without them, people can, not always, but many women experience these symptoms. And we know from our vast clinical experience, but others have reported it for decades, actually, that women often feel better when they have hormones. But there seems a real problem because a lot of people will say, well, where's the good studies? Where's the randomized control studies? You don't always need a randomized control study to prove basic physiology and common sense. Even if you think about exercise, you don't have to prove by having a group of women that never exercise ever that exercise is good, because you wouldn't restrict exercise in people knowing that it's good for us. And it's the same with hormones. When we just give hormones, it's the replica of the hormones that we have when we're younger. So it's not a synthetic, chemically altered drug, if you like. But people do feel better, and it's not a bad thing that people feel better. But on the more extreme side, 1 in 6 women who come to our clinic have suicidal thoughts. A lot of people have had very dark clouds over them. They feel very worthless, very joyless, very upset. And they have, like you say, been medicalized, often for many years, actually. And there's this term, treatment-resistant depression. And there was an article actually in the paper yesterday talking about another clinic being set up in Scotland to treat these people with treatment-resistant depression with ketamine. And ketamine is a horse tranquilizer. It's a street drug. I'm sure people feel better on ketamine, but I'm not sure that's really always treating the underlying cause. And we see people that have had electroconvulsive therapy, they've had lithium, they've had olanzapine, they've had ketamine, and they're telling us they don't feel any better, but they're also telling us that their symptoms started in their mid-40s, and they've always had a bit of PMS or PMDD, and it's got worse. And these symptoms are associated with the dry skin, urinary symptoms, palpitations, and you're like, sounds like some of this could be related to hormones. And often balancing their hormones, especially without adding testosterone, can just be transformational for these women's mental health. So we see it all the time. It's been researched for decades, but most psychiatrists don't prescribe hormones. And it's a great travesty for women out there who are suffering with their mental health.
I think another major argument I would point to would be, you talk often about bone density and again weighing up, because as you well know, Louise, you're on the brunt of some pushback against HRT, and the obvious argument against it is breast cancer, which you've heard a million times. And the other thing that you say, well, one, for me, mental health, is huge, and secondly, as you say, osteoporosis and the fact that the bones are weakening. So, do you want to speak about that as because I think they're the two strongest suits, perhaps, to weigh up against that
Absolutely.
possible risk.
Yeah. So osteoporosis is this thinning of the bones that most people don't know they have it until they have a fracture, but it's a fragility fracture. So if you like, a low impact fracture. If I if I fell off a motorbike, not that I go on a motorbike, if I did at a high speed and had a fracture, well, that's not a low impact. But if I just stumbled over the carpet and fell over and broke my wrist, that's going to be a low impact. So it shows the bones are just weaker, they're more fragile. And we know that our bone density reduces as we get older. But we know there are certain things that accelerate that bone density. For example, drinking alcohol, taking steroids, smoking, family history can as well. But the big thing in women is not having hormones. So if people are menopausal, they have an accelerated bone loss. And actually in perimenopause, it's around 16% of our bone loss is lost during this time. Because estradiol, progesterone, testosterone work on the bones. As you know, the bones are metabolically active. So when we don't have those hormones, there's an increased bone turnover, there's more bone loss, and this increased risk of osteoporosis. And this is important because osteoporotic hip fractures are obviously painful. Most people need an operation, but there's a 20% 1-year mortality after them. So 1 in 5 women will die that year after. And they often are associated with reduced mobility and so forth. Fractured wrists are very common. I'm very scared of fractures of my spine if I developed osteoporosis, because that can cause, postural problems with your posture, but it's painful. And then people find it's really hard to sometimes breathe, digest food, and so forth as well. But osteoporosis, like I say, unless people have DEXA scans, bone density scans, they won't know they've got it. And we've known for nearly 100 years, actually, that if women take hormones, they have stronger bones. So it's very important when we think about this, because around 1 in 2 women who are menopausal will have osteoporosis. So it's very common, 1 in 5 men as well. So we need to think about this. But then when you think about the breast cancer risk, any risk with breast cancer has been shown with older types of hormones, and hormones that contain synthetic progesterone, a chemically altered progesterone that is actually in all the contraceptive pills. But in hormones, we don't prescribe those anymore. We prescribe the natural progesterone. The estrogen has never been shown to be associated with increased risk of breast cancer. So women are being denied an evidence-based natural treatment on unfounded fears, actually, because the evidence has been misreported in the first instance. But even so, even if you look at the worst write-up of that study from 2002, it was all using different hormones to what we use now. So it would be like saying to you, this study was done on chicken flavor crisps and they're not very good for you. And you're going, but I eat roast chicken, like there's a difference. And that's exactly what's happened. So we're in a real mess. And people who push back and don't understand hormones is because they're grouping them all together and they're not understanding the difference.
Mm-hmm. Yeah, I hear you say that a lot. That basically the hormones they're given now just completely different. I mean, the actual hormones rather than synthetic,
Absolutely,
which is constantly going to make all the difference. But I mean, just as a sideline, so the pill, they're still giving that synthetic one, and there's no real hormone pill, right?
There isn't a hormone pill, isn't that a shame? There's one type of contraception that contains estradiol, but all the others contain ethinyl estradiol, which is a synthetic estrogen, and they're all added if they're a combination pill with a synthetic progesterone. Even the progesterone-only pill it's referred to isn't progesterone, it's a synthetic progesterone. And they all have risks. Now, the risks are small, and your risk is less when you're younger, but the risk is still there. So, if my children, I've got 3 daughters, if they took contraception, they would have an increased risk of clot, heart attack, stroke, breast cancer. Small, but it's still a real risk. And this is this isn't me making this up. This is documented science. But we sort of ignore that. But somehow when we say HRT, we're all going, oh, no, I don't want to take it.
Why do you think that there is such such lobby against HRT that it's causing breast cancer? Then, because by what you're saying, and obviously I've heard you speak a lot, it seems like if you weigh up the risks to the possible benefits, it's really a no-brainer. But yet there's so much resistance. I mean, and even I have to say, when I asked my student body, this was coming up a lot. Oh, but it's HRT, we don't want to take the hormones. How would you argue it, or to these people that are resistant? I mean,
So,
if one is
yeah,
too hormone.
and I get that. It's the biggest thing that people are scared of. And it's because of misinformation, actually. And it's people that haven't had the knowledge and haven't thought it through properly. And the problem is, these people have got loud voices. It's continued in generations of people. And so then I think we have to challenge the evidence properly. We need to look it through. And I'm very interested in basic physiology. I've got a pathology degree, so I'm very interested in how science works and how, medicines help or can cause side effects to people. So it's looking at the actual evidence is really important. Now, it's always hard, isn't it, with breast cancer? Because now 1 in 7 women get breast cancer. When the big study came out, actually scaring women around from hormones, it was about 1 in 12 women. So breast cancer incidence has increased despite HRT prescribing really falling very low. So what that means, on average, 1 in 7 women taking HRT might develop breast cancer. And a lot of these women are then told, oh, it's your hormones. Well, how do you know that? And we don't know that at all. So that's always going to be scary for women. Like, how do you cope with that if you've been taking something? But there is no evidence. The problem is that all our hormones, whether we have them as natural hormones, whether we use them as vaginal hormones, which are very, very low dose, all the labeling is about breast cancer and heart attacks and strokes. So that's quite disconcerting, for everybody. So even if you've got the confidence and you've got your HRT, you open the packet and then it comes out with all this warning and you're like, oh my goodness, is this really right? Who is this doctor? What's she doing? No, I'm very proud to say I don't work with any pharmaceutical companies. So I have no agenda to push hormones at all. And that's really important because a lot of people and a lot of menopause societies and specialists do get funded. Not totally, but they do receive funding from pharmaceutical companies. But there's also, a lot of women who don't take hormones, take other medication. We do a lot of de-prescribing. We've mentioned the antidepressants and antipsychotics. A lot of people are on painkillers, sleeping tablets, blood pressure treatments, statins, and so forth. So that sort of filled this void, really, for women not having HRT. Then some people will say, well, you're playing with nature. Surely we should just carry on and not have it. But then we have to think there's 2 things that I would push back on. In that around 1 in 30 women under the age of 40 have an early menopause. It's not natural to have a menopause at a young age. So these women, we really have to think about hormones for their future health. But the other thing is we're actually not really designed to live so long without our hormones. Evolutionary, we're designed to reproduce and then die, really, because that's how people have in the Victorian times. And we play with nature all the time as doctors. We prescribe treatment for osteoporosis, which is associated with aging. We prescribe blood pressure lowering treatment because blood pressure increases with age. We give people painkillers when they're in pain. We do this a lot. But then, it's about choice. I don't mind at all what people do. It's the same with exercise. We tell people they should exercise, and isn't it great if they do? They don't. It's their choice. And it's the same with hormones. But what's happened for especially the last 20 years, but it's gone on for decades, is that women aren't allowed a choice. The doctors have been deciding for them. And this is where I feel it's really sad. Because if no one wanted hormones, I wouldn't bother with my work, because why would I? But I hear every day women just being told, it's all in your heads. It can't be your hormones. You don't need hormones. And I think that's really sad. And I think some of it is actually just because it's a women's problem. And women need to just get on with it and shut up and put up, because that's what we're good at. And I don't think that's good enough when we're also draining resources, healthcare resources, when we're older because of the osteoporosis, the heart disease, the dementia, and so forth. So we all need to be waking up and thinking about it differently, I think.
I think the argument from nature is a tricky one because, well, I mean, there's many things in nature that don't work that well. So we've augmented nature for so long. So I might tend to look at that slightly skeptically. Maybe you could talk a little bit more about that kind of going to the. I think you've talked about going to the GP yourself and how it's kind of nerve-wracking and frightening. And I had the same experience with my wife. We went to she had breast cancer, and we had a lot of these talks to surgeons and clinicians, and you do feel like an idiot, really, oftentimes, right? Like they're in authority, they're using the big words, they're this esteemed person, and you feel like you can't speak back. They're telling you what's going to happen, and you haven't got a voice. So, and I think that's that was our experience. Certainly, that's many people's experience, I think. So I wonder, if you could offer any advice about this, being a GP yourself, right? How to talk back.
No, it's really important, and my sort of clinical practice has changed a lot over the last 30 years. And when I did hospital medicine, it was very dictatorial. You've got X condition, I'll give you Y treatment, off you go, I'll make you better. And then when I trained into general practice, I spent a lot of time learning about consultation techniques and how to put the patient in the center and allow patient a choice. And the first time my trainer said to me, well, why don't you ask the patient what they want? I was like, oh, don't be ridiculous. I think I'm stupid. Like, it's obvious they need antibiotics or whatever. He said, no, try it, Louise. And then when you do, it's amazing what you get out of patients and what they talk to you about their fears or their concerns or their beliefs. And I've done this a lot. And because I've worked as a medical writer for a long time, I've always been giving information to people in the way that they want it. So it might be written, it might be verbal, it might be a combination, but it's based on science and evidence as well. And then it's amazing when people, as in my patients, are empowered, because you can have a different level of conversation. And this is where medicine has to be individualized. It's really important, because everybody has different beliefs, different concerns, they have different symptoms, they have different risks of future conditions as well. So it's not a, conveyor belt medicine that we should be practicing. And so much in medicine is, the guideline says this, therefore we do this. And, if you don't get better, then it's not my problem because I've treated you in this way. And of course we can't do that. We have to look at so much more. And we have to look at more than just medicines as well. You mentioned at the beginning that I do yoga. Like, I can take all the hormones I like, but I tell you what, if I never did yoga, I keep saying to James Critchley, my instructor, I think I'd be such a different person. I know I would be, but I'm not going to stop it to see. But it's very important as a doctor that I'm listening and thinking of holistically what's going on in that person's life as well. And that's sometimes forgotten in medicine. It's about a tablet, a medication, and then you get out of the room and you carry on your life. And we can't do that, I don't think, anymore.
I don't think you also mentioned that if you don't get an answer that seems reasonable to you, or you're looking and you do want HRT, for example, and the doctor is unwilling to prescribe them, then go and see someone else, and
Absolutely,
get a few opinions, get more than one opinion.
I think it's really important, do your research as a patient, find out about the person that you're seeing. And, if it doesn't work for you, that consultation, it's probably not working for that doctor either. As you know what it's like. If you're with someone who's nervous, you feel nervous. If you're with someone who's sad, you feel sad. So as a doctor, if I'm feeling a bit not sure, I'll often say to the patient, am I helping you? Am I making sense? Is there something else? Is there, but if they go off and say, oh, I saw Dr. Smith down the road and she was brilliant, that's fine. And doctors should be like that, because we are different, and we shouldn't be there as dictatorial people telling people what they should and shouldn't do. And also, I think as patients, we're allowed to change our minds. So we might have had a consultation one day and said, yeah, you know what, I really want this treatment. And then the next day gone, no, actually, I think I'd like to try something else. We're allowed to do that. We should be in control of our bodies. And when we're talking about hormone health, it's crucially important, because our hormones or lack of hormones will last forever. So we need to make important choices, and it can sometimes take a while to make that choice.
And different GPs and medical professionals are going to give different advice, right? We assume that it's one homogenous body. As you also mentioned, you've got many arms to that body, and many people seeing a different side of that cube. Look around and get the. I think what's coming through every time in your answers is get the information. Find it's out there, right? And come armored with information, and then you can make the better choices. So kind of like finally wrapping up, what about if you are going to take HRT? Is there a particular type you would look out for? Because you mentioned people kind of getting fobbed off with the wrong type they're given. Yeah, and the dose. Talk about maybe what kind of dose one could expect.
Great question. So it's really important that we have our natural hormones if possible. So and I prescribe separately because the combination ones are always synthetic, usually the progesterone. So we've had the natural estradiol, the natural progesterone, the natural testosterone. So the estradiol is usually a patch or a gel. So it goes through the skin straight into the bloodstream. There is a spray, but in my experience, it doesn't get absorbed very reliably. So the patch or the gel, there's different manufacturers of each. And, the skin's quite hard to get things through. That's why we don't use many drugs through the skin. And so the dose does have to be individualized. When we give HRT, if we start in the perimenopause, the woman's still producing some hormones. So we might just start with a low dose, and then the dose has to change as their own hormones reduce. But some people, including me, find that it's very hard to penetrate the skin. So they might need a higher dose to just get it through the skin into the bloodstream. Progesterone is often an oral capsule, but it can be used as a pessary as well. And then it's just a way of getting it absorbed differently. And testosterone is either a gel or a cream. So again, through the skin to get into the bloodstream. So we have options. And we constantly, when we see people, we often do a blood test to see how they're absorbing. But we're just assessing. So I've tried the gel and it literally just floats off my skin and drips onto the floor. Like, it doesn't matter how much I use, it just doesn't get absorbed. So therefore patches are better for me. But other people find patches don't stick at all and the gel is better. But there's also an estradiol tablet. So sometimes we use the tablets, or we might use a combination. Like, everyone's different. So, but it's not a one size fits all. That's really important for people to know.
And there's no age window for this, because I think people also assume, well, I'm 50 now, my menopause is finished, and now it's too late for HRT, or I'm 70, I can't go on it. You can go on any time, is that right?
Yeah. No, it's not too late. So in the past, people were worried about the breast cancer risk, the clot risk, the heart attack risk, and said you shouldn't really start it in older people. But this was the synthetic. Like, I wouldn't start anything that's synthetic in older women. But the natural hormones, of course, you're just topping up, so it's fine. And vaginal hormones, of course, are safe at any age as well, and including women who've had breast cancer can have vaginal hormones usually. So no, the oldest person I've started HRT on was actually 90. For her 90th birthday, she treated herself to an appointment, and then 6 weeks later, she phoned the clinic and said, "Oh, can I start some testosterone now? I feel great." So,
Fantastic.
it's about choice. If older people start it, and if they don't feel better, they can stop it. It's fine.
And even if say, for example, someone's had breast cancer or they have history of breast cancer in the family, would you advise them not to go on it? Would you say, they can still go on it?
It's very individualized. If women have had breast cancer in the family, then there's usually absolutely fine for them to take hormones. When they've had breast cancer, it depends on the type of breast cancer, it depends how long ago it was, it depends on their symptoms, it depends on their choice. And it depends on the hormone, actually, because sometimes we just give testosterone for women who've had breast cancer rather than giving estrogen, for example. But what's really sad, we did a study recently looking at how women who've had breast cancer are spoken to just about their menopause, not even about treatment. And it's just disgusting, actually, what's going on out there and what women are being told, and they're being bobbed off with other medication. So we see a lot of women in the clinic who often really struggled with symptoms, and they make choices, and there isn't good data either way to say it's harmful or it's safe. So often we go with our experience and knowledge and share uncertainty with patients. So it's an area that desperately needs research, but no one's doing any research into. So in the meantime, we work with our limited evidence and help people as much as we can.
I think because the drugs are cheap, right? I mean, you can't make that much money off hormone replacement drugs, so that's why no one's really kind of interested in doing that, right?
Yeah, because they're the natural hormones. It's not a new formulation. Like, if I was a pharmaceutical company, you would want to make a new drug with a new chemical structure that you can patent, like you say. When a drug's got its patent, that's where you make your money. That's where you make your millions. You can't do it because I'm not going to take, as a menopausal woman, anything that's not estradiol. So you can put it in a nice fancy packaging, but you're not going to make money out of that.
Right. So they could be prescribed something that's not estradiol as well, which you wouldn't like so much.
Yeah, well, it's not natural for the body. It's the chicken flavor crisps again
Right.
that
Okay.
probably
So
don't have any chicken in it, you
right,
know? So
estradiol is the natural one, right? So you have to
yeah.
check. So you have to check that what you're being prescribed is that
Yeah,
estradiol.
but if it's
Yeah.
a patch or a gel of estrogen, then it will be
Then it will be.
estradiol.
Right. Okay.
Yeah.
Right. And you can stay on this for. Do you have to stay on it for life, or can you come off? Or
You can do what you like as a
right.
patient.
Okay.
It's up to you.
Right.
So, but most of us stay on it for life because we take it not just for symptoms, but for improving our future health. So, if I came off my hormones, I probably would have some symptoms. I might not, but I'll have that bone turnover increasing straight away. And, risk of heart disease, risk of autoimmune diseases, risk of inflammatory conditions. So that's where it becomes a choice. You have a review every year and decide if you're going to carry on. But most people carry on taking it forever. Yeah.
I assume also you give some natural kind of remedies, either as an auxiliary practice or in replacement. What other things can people do to augment their taking of HRT, or if they don't want to take it?
So you can't replace hormones in any other way. I mean, our muscles do make small amounts of hormones, so exercising will release some hormones into the bloodstream. But it's really important we spend a lot of time just thinking about future health. So some people do take supplements, vitamin D, some people take fish oil, magnesium, various vitamin Bs, for example, but that's for their future health. That's not for their menopause. And there is a distinction between the two. It's like looking at any lifestyle factors. It's really for future health rather than menopause. There's lots of supplements out there that are labeled for menopause, and it's not actually that helpful because it's not replacing the hormones.
Right. And exercise brings up the level of estrogen or testosterone?
A little bit, but not enough. And this is where women are being gaslit and told if you exercise and eat well, you'll feel fine.
Right.
Well, do you know what? I tried my best before I experienced symptoms, and you can't have the same levels. So you should still try and exercise, but you shouldn't be. I feel very strongly women shouldn't be told to do that first before hormones. Because often when people have hormones, it's so much easier to exercise. It's so much easier to sleep. It's so much easier to cook good food because you're back in the game. You can live a lot better. So when people are told go and improve your lifestyle and then we'll think about hormones, it doesn't make sense.
All right, that does make sense. Yeah, I have to, as a man, bring it back to me as a man in the end, as all men do. What about testosterone then? I mean, this is really super trendy these days. We see people like James Smith coming out and saying he's taking the TRT. As a man of 46, what do you think? Should I be considering it?
Testosterone is a really important hormone for men and for women. It's a very biologically active hormone. It affects every cell in our body. It's made in our brains. For us, it's made in our ovaries. For you, it's made in your testes. And about 30% of men will have low testosterone with increasing age. Hard to predict when. People who tend to exercise usually keep their testosterone a bit more. Generally, when men who are overweight don't exercise will have low testosterone. But you can measure your level. It should be done before 10 o'clock in the morning. And if your level is low, there's good guidelines that you can try testosterone. And there's plenty of evidence for men that men who have testosterone have a lower future risk of heart disease, type 2 diabetes, osteoporosis, dementia, and so forth. So it's an important hormone. It's not just so you can keep on being down at the gym. It actually can help your future health. So again, it's just not considered important for a lot of doctors, and it's relatively cheap as well. So it's never been prioritized because people think it's just about libido and sex, and it's absolutely not. It works all over the body.
Or steroids or something, going.
And this is this is like the chicken flavor crisp, like testosterone that people inject, do down the gym, whatever. That's not proper testosterone, so it will work as an anabolic steroid. It will affect heart function abnormally because it's not the same as natural testosterone.
Thank you, Louise. That's been a great chat, very informative. Any parting words for our lady yoga students out there about yoga? I mean, you're a yoga practitioner, you're also a GP, you're also a menopause expert. You must have a few specific things to say about your own practice or experience of yoga. I'm sure there's something.
Yeah, I wish I was more in tune with my hormones when I started to have symptoms, because the first thing I noticed was my yoga practice wasn't very good. And we all have days doing yoga. Like I did yoga this morning and I thought, God, I just feel like dough. Like I don't feel great. And I hate those days. And I don't know why they happen. And other times I do yoga and I think I could just it's brilliant. And you know that, I'm sure. But when I was perimenopausal, I had a lot of muscle and joint stiffness and I had low energy. And my yoga practice was really rigid. Like it was really, like it didn't flow at all. And I didn't progress. And often you do progress with yoga, or sometimes you don't progress, but you don't get worse. And I was really I reached this hiatus where I was like, you know what? I don't really care if I do yoga or not. And that's a bad place to be. So if you do yoga regularly, you'll know your body, I think, a lot more than if any other Of course, I'm pro yoga, but it just helps in so many ways. But if you're in tune with your body and you feel it's not working for you, download Balance, the free app that I've created. Do your symptoms, find out some information. Just think, could it be related to hormones? And even if you don't think you could be perimenopausal, but you're getting symptoms before your periods, think about PMS, PMDD. There's lots of information we've got about that as well. And think about hormones just for those few days. So just be really in tune with your body and don't think that you can just exercise your way out of it. You know, it's important to have that knowledge. And even if you don't have symptoms, have that knowledge. Even if you're a male listening, still have knowledge because you can help others. And that's what all of this work's about. It's just helping others to be empowered with information so they can make choices.
Thank you. A wonderful chat. And we'll put the links to the Balance app and other links in the show notes for everyone. Thank you again, Louise. It's been very informative and super helpful, I think, for many of our audience. So thanks again for taking the time to come on out of a very busy schedule, I'm sure. Thank you.
Oh, thanks for your invitation. It's been great.